Let's talk about gastric adenocarcinoma. One liner. It's a stomach adenocarcinoma with invasion at least into the lamina propria, where 90% arise sporadically due to chronic H. pylori infection, most commonly over EBV, tobacco diet, and 10% in a familial setting, including hereditary diffuse gastric carcinoma syndrome, with many histologic subtypes like tubular, papillary, poorly cohesive, mucinous mixed, and HER2 immunohistochemical testing is highly desirable. The location depends on what country you are from. In Asia, Central and South America, Eastern Europe, 80% of gastric adenocarcinomas are distal, meaning the body, the antrum, the pylorus. In Northern European and America, 50 to 60% are in the cardia or fundus. As per the AJCC 8th edition, tumors involving the gastroesophageal junction with the epicenter less than or equal to 2 centimeters in the proximal stomach is considered esophageal adenocarcinoma. If the epicenter is greater than 2 centimeters into the proximal stomach, then it's considered gastric carcinoma, even if that cancer extends into the gastroesophageal junction. Etiology. Sporadically, it's thought to arise from chronic inflammation leading to dysplasia and carcinoma. So H. pylori leads to chronic inflammation that leads to intestinal atrophy. The epithelial cells undergo metaplasia, undergo mutations leading to dysplasia, and you'll have a field cancerization effect. And so you have a synchronous risk of developing cancer in that region of the stomach. Histologic subtypes, there are many, but five main recognized ones as per the WHO 5th edition are tubular, papillary, poorly cohesive, mucinous, mixed, and other subtypes that they do recognize are parietal cell, Pannis cell, micropapillary, mucoepidermoid, gastric carcinoma with lymphoid stroma. Often EBV is positive, so make sure to get an EBV-ish, hepatoid, and gastric carcinoma of funded gland type. Macroscopic appearance. The term Linitis plastica or serous carcinoma is used when there is abundant fibrostromal reaction, leading to a gross appearance of thickening and rigidity of the gastric wall. And here's a gross specimen of a stomach laid open of Linitis plastica. And you can appreciate the waffle-like appearance of the folds, and there's loss of extensibility due to the infiltration of cancer cells. Here are the histologic subtypes. There's tubular gastric adenocarcinoma. This is the most common subtype, ranging from 45% in Europe to 64% in Japan. Architecturally, there are dilated or slit-like branching tubules, as you can see here. Acinar structures may also be present. Cytologically, individual cells can be columnar, cuboidal, or flattened by prominent mucin or debris. Here, they're predominantly columnar with invasion into the muscularis propria. Poorly cohesive carcinoma, can be further divided into signet ring cell type or NOS. This is signet ring cell type, where the signet ring cells, as you can see here, the nuclei is pushed eccentrically due to the mucin production, and they are larger towards the mucosa and become smaller further down, which can be tricky. And this is the other subtype, the poorly cohesive carcinoma NOS, meaning non-signet ring cell type. In this cell type, the neoplastic cells can resemble histiocytes or lymphocytes. Other times they can be pleomorphic with bizarre nuclei. The neoplastic cells in this case look lymphocytic to me, and this, I would say, is even scarier than signet ring, poorly cohesive carcinoma signet ring cell type, because it looks more bland and less conspicuous. There's mucinous gastric adenocarcinoma. This accounts for approximately 2.1 to 8.1% of gastric adenocarcinomas. The tumor contains malignant epithelium and extracellular mucin, which needs to account for greater than 50% of the tumor area to be considered mucinous. Two different patterns can be seen. You can have glands or tubules lined by columnar epithelium with interstitial mucin, and the second type is chains, nests, or single tumor cells, including signet ring cells surrounded by mucin. Papillary gastric adenocarcinoma. This is a relatively rare subtype, 2.7 to 9.9% of gastric carcinomas. On gross exam, there is an exophytic growth pattern, and architecturally, there are finger-like processes within which are fibrovascular cores, as we can see here. Cytologically, the cells can be columnar to cuboidal. Here they are columnar and a little bit of cuboidal as well. Despite being a well-differentiated tumor with pushing edge and frequent inflammatory cell infiltrate, papillary adenocarcinoma is associated with a higher frequency of liver metastasis and poor survival. Other subtypes. This is a low-power view of gastric adenocarcinoma of the fundate gland type. The tumor centrally infiltrates into the submucosa, presumably develops from an oxytocin gland adenoma. It can be divided further into chief cell predominant, which is 99% of cases, parietal cell predominant, and mixed phenotype. This subtype is slow growing and lymph node metastasis is rare. In the central region towards the submucosa, you can see these group of cells are much more basophilic and probably due to a higher NC ratio. And as we look closer, you can see some cribiform architecture. Cytologically, there is amphiphilic cytoplasm with some nuclear pleomorphism and occasional nucleoli, and some regions of nuclear polarity loss. As you can see here, the nuclei are more jumbled up and mitotic figures. Gastric adenocarcinoma with lymphoid stroma. This accounts for 1 to 7% of gastric adenocarcinomas. Also has been referred to as lymphoepithelioma-like carcinoma and medullary carcinoma. So it gets a bit confusing because there are different names for it. Architecturally, there are irregular sheets, trabeculae, ill-defined tubules or syncytial polygonal cells with prominent lymphocytic infiltrate with intraepithelial lymphocytes. The reported rates of EBV infection can be from 22.5 to 100%, so get your EBV-ish if suspected. It's more localized in proximal stomach and more common in men. And here is an EBV-ish or in situ hybridization from that same case, and it's positive. Hepatoid adenocarcinoma. Cytologically, there are large polygonal eosinophilic cells resembling hepatocytes. Bile and PASD positive intracytoplasmic eosinophilic globules can be seen. AFP can be identified on IHC in the tumor cells and in serum. However, other variants of gastric adenocarcinoma, including well-differentiated papillary adenocarcinoma and adenocarcinoma with enteroblastic differentiation, may also produce AFP, so it's not specific for hepatoid. And to make it more confusing, these histologic types may even coexist within the same tumor. So you might have hepatoid with well-differentiated papillary with enteroblastic. Prognosis. PT1, meaning tumor invades furthest into the submucosa. It can be further divided into PT1A, lamina propria, or B into the submucosa, but they just group that all together. And PN0, studies have found 5-year survival is greater than 90%. PT4B, where the tumor grows into nearby structures and organs, the 5-year survival is 30%. PN3B, where lymph node mets into 16 or more lymph nodes, the 5-year survival is 20%. Why do we do HER2 IHC testing? It benefits patients with unresectable or metastatic HER2 gastric carcinoma. So it helps us to tell the clinician this patient has HER2 positive gastric carcinoma. Credits are with the WHO 5th edition, including the photos. So thank you so much. If you enjoyed this video, it would mean a lot if you can give a like and subscribe. Thank you so much. Bye.